Hey, everybody. Welcome to another episode of the Med List. We're so happy to have you guys here. We just had a Super Bowl happen, Donna, and I know I'm
Yes.
touching on some emotions here across the play. I did hear one thing I loved. It was, are you rooting for Kansas City, the 49ers, Usher, or Taylor Swift? And so I thought that was lots of different camps to be able to have there. Did you guys have a little bit of a Super Bowl party your way, and any favorite Super Bowl like treats?
Oh, Super Bowl treats. Um, you got me on that one, Kevin, because it's all
On
so
purpose?
good, right? I don't know if I have a favorite. I'm just gluttonous on Super Bowls today. So,
That's
but
cheat
no,
day.
we had birthday parties too, and just lots of moving pieces. But yeah, it was just such a fun day all around from start to finish.
Oh, good. I'm so glad. Well, this episode is going to be a fun one. It was so nice to just meet Nikki off the bat. Just feels like I've known her forever already, and so I'm really excited for you guys to hear from her and her experience when we really go into the aging process. Which that's one nice thing about family get-togethers is you get
Yeah.
multiple generations in one space to do those kinds of things. The Super Bowl included. You can all yell at the exact same team and root one way or the other. And we'll be rooting for Nikki during this episode of the Med List. We'll get
Yeah.
started right now. Awesome. And you guys all know how much we love the aging process and making sure people are aging successfully. And we're bringing on one of the experts in our country here. So
Mhm.
without further
Absolutely.
ado, Donna.
Yeah, I know. So today, welcome, Nikki. We have Dr. Nicole Brandt with us. Just an amazing mentor for me, even through the years. I don't even know how many years I've known you, Nikki, but we don't have to go there.
We
But
will get
anyways, yeah. But just really, you are a force in the pharmacy field and especially in geriatrics. So Dr. Nicole Brandt is professor and executive director of Lammy Center on Drug Therapy and Aging out of the University of Maryland School of Pharmacy. And just looking at your background too, Nikki, and knowing your business development side of things, research, pharmacy, healthcare, gerontology, leadership, there's just so many things that we can say about you and your talents and skills of being really just an amazing person in the field of pharmacy, in the field of geriatrics. You were also the past president of ASCP, and I have to say, that was a very special time for me in ASCP. It was just very empowering for women in pharmacy and women in geriatrics. So thank you for that. And I will let you talk a little bit more about yourself and just tell us a little bit more about you and how you got into all of these amazing areas of pharmacy.
Oh, well, thank you, Donna and Kevin, for the invitation. And thank you for the listening audience for being present whenever you're present. So, with respect to my roles throughout my career, I think one could say I love a new adventure and how to reinvent oneself every 5 years. So, Donna, I'm happy to share with you. It was also an amazing time being within leadership at the American Society of Consultant Pharmacists, excuse me, and working with the different board members and different members, and really just traveling throughout the country and listening to our members. I think that's so empowering. And so it's kind of a nice segue to some of the work that we're going to be talking about. But just a little bit about me. I'm originally from upstate New York. I was sharing a little bit about football before you guys started talking, and diehard Buffalo Bills fan. So I won't go into my favorite from the Super Bowl yesterday, but one of these days we're going to win a Super Bowl. That kind of speaks to my underdog spirit that I have. So I've loved working in the field of aging. My whole career has focused on aging. And my passion has been about improving medication use and safety for older adults, and probably stemmed out from experiences both personally and professionally. During my postgraduate training program, I worked with the Visiting Nurses Association implementing public policy in assisted living facilities before we really talked about assisted living facilities in the late 1990s. And it really empowered me how it was so important to have housing that was affordable, that provide medical care. And those kind of nuances traveling all over the state of Maryland, where I did my my work with the VNA was so powerful because it made me realize that small homes, large homes, that there's just a disparity and an access issue, even in this state, which is quite small, honestly, but there's a lot of rural spaces and places. And those early experiences really empowered me to do more. And so when I had opportunities to spend some time at the Centers for Medicare and Medicaid Services, that raised my awareness to long-term care policies and practice. I spent a couple of years there working on the state operations manual and educating surveyors. Then I realized that healthcare was changing. It was right about the part of Part D in the 2006 timeframe. I always phrase it about the time I had kids. So that was my second child. I was going into labor when this SOM was coming out. So, and now my son is almost 18, and just realized like time flies by. And it's so important to kind of enjoy those milestone moments, just not professionally, but also personally. And then I realized I'm like, oh God, healthcare is so business oriented. And I am a clinician at heart. I'm all about patient-centeredness. We'll talk about that in some of the programs we've done. But I also realize you can't sustain programs if you can't sustain a budget and financial measures that matter. And it depends who you talk to. So after my experience in the government at CMS, I went back for my master's in business administration. And it really made me think differently, just like any training does, makes you think differently. And I think that really helped me to kind of strategize, and then had this opportunity of leadership with ASCP. Then I took the helm of the Lamy Center back in about end of 2016, early 2017. So I just aligned where my passion is, which is in aging. So that's kind of where I'm at. And I feel like I'm at a stage of life where I love to pay it forward to our future generation, both through teaching, but also public policy. So we've been doing a lot of work, both in the local as well as national, and now some international work that I just got back from, as you know, with my Fulbright.
That's
Wow.
great.
Yeah, I think the first thing that we were talking about, Nikki, I'd really love to hear a little bit more about your Taylor Swift background at a later date. We'll save that. Anyway, but going into some of the aging background pieces, I do think that's really curious there when you talked about going overseas. Any elements that you'd say, Nikki, from just your experience here in the US and the developing models you have seen versus overseas on the way that we're handling our aging populations and adding some cultural elements inside of it? I'd love to hear some of your perspectives you gained from such a fresh in your mind trip.
Yeah, so thanks, Kevin, to give the audience just perspective. So I had the privilege to go to Finland to do a Fulbright program specialist, and the focus was on age-friendly work. And they, in 2023, implemented a public policy which aligns healthcare and social welfare programs from a reporting and programmatic perspective. We've been working with the University of Helsinki, the School of Pharmacy primarily, for the last 5 years with one of our Aging in Place courses, which is about all teach, all learn, in terms of helping the community learn from students and the students learn from the community. So it's a teaching community classroom. So we go out into the field. That has broadened our work in terms of our being based in some of the senior housing settings, providing actual hands-on care and community empowerment, engagement, and follow through with our Aging in Place clinic, which is done with the School of Nursing here and the School of Pharmacy. But getting back to the Fulbright, it is oftentimes students are in the classroom, but they don't get out to the community. So during my trip there, we actually met with some of the community partners so we can then have our students go out to some of these community settings. So I have to share with you one of the most fabulous aspects, and I wrote a series of 3-week blogs I could share with your readers, but I went to a place called Milleporo, and Finnish is not an easy language. Mind you, Kevin and Donna, my husband is from Finland. And we don't speak Finnish at home, we speak Swedish, but needless to say, I won't start speaking that language either because I'm not that fluent. But it was fascinating going over there, being immersed as a healthcare provider and not as a daughter-in-law. So that was the first lesson learned. And just appreciate some of the personal aging aspects that influenced my desire to learn more about their medical model. So the biggest thing was this alignment of healthcare and social welfare programs to monitor some of that kind of meaningful work. And so Finland has been pushing for it to become an age-friendly country, but they really haven't focused as much on the age-friendly healthcare aspect of it. So that's why I was over. So I did a series of seminars. I learned from the students, again, that philosophy, all teach, all learn in the classroom. But I also went to many sites throughout southern Finland to meet with the health systems and also thought leaders years. We had a wonderful session meeting with an older adult who just wrote a book about some of the beauties of aging, and met with another author who talked about some of the social policies with aging. So it was really fascinating. And I think, as I mentioned at the beginning, it's always great to reinvent yourself, be creative. So going over there and learning about global policies and how that can bring some of those lessons back here, but how we can share in that exchange. So the work has been ongoing, and this just built the stronger bridge between the partnership between the universities and honestly between the age-friendly movement that's happening globally.
Tremendous. Now, with that particular population you're looking at, when it comes to aging in place, the curiosity I always have is me having a Native American background and seeing the way that we can either see some multi-generational housing, some senior living communities, step down communities that end up happening. And the exact same experience. My residency was also with the VNA. And so you see all kinds of living situations. In Finland in particular, what were you seeing as the majority of the model for most people aging in that particular country?
It's in the community, Kevin, and thanks for sharing that. That's really powerful. And there's this movement for intergenerational living. And so what was fascinating about this place that we visited was it was an old hospital system that got renovated to be kind of a community building. So the first floor had a restaurant, a library, some social services, a hairdresser. I probably could have used one, but and this meditation room. It was just lovely. Pool tables. It was very, very community. As you progressed up, the second floor was home care, if I remember correctly. The third floor was day programs and respite care, and then the fourth floor was nursing home. It was all in the same building. And so there was art rooms, there was sewing rooms, there was community engagement, kind of getting at some of that social isolation. They had affordable transportation that was reliable to get there. And the programs were also affordable. And so they worked with people's income and social structure to help with that. But it was across the street, or the trail, I like to say, because there's a lot of paved walking pathways from an elementary school. And so some of the younger generation would come over and work with the older adults. And it was just very easy to navigate to. And so it was just very impressive, because we know that mobility is such an important aspect of feeling connected with your community. And it was accessible. Despite, mind you, it's January in Finland. There was a lot of snow and ice, but it didn't stop a lot of the older Finns from getting around.
Wow.
Yeah.
So, Nicole, I find that really interesting, because I think some of the models that have spoken to me in various parts of the world, and what we don't have here necessarily in the United States, are these community type of environments. And so many times we have wards that are like locked memory units and things such as that. And in other countries, they have like a beautiful area where there's separate apartments and a green lawn area, and that's the memory ward. And they're able to go outside, get fresh air, sit on a patio kind of thing. And it's unfortunate that we don't necessarily have that model here, and I would love to see more of that happening. The one thing that I find really interesting, though, and I hope I have this right. I believe Finland is one of the countries that spends a lot of money on older adult care too, and also on aging in place, if you will, where in the United States, our funds for elder care is very low comparatively. There's big gaps, of course, with the amount of money that we pay and what the federal government pays for healthcare. And we see that those models in some of these other countries is very different. Not that I want to get into a political conversation, but I just think, like you're talking about, that whole business model, it's where are the funds coming from, and how do we make this affordable for people? Because it is so expensive in order to get that health care in the United States, I believe.
Yeah, no, and Donna, you hit on something. I think many countries with a rapidly growing aging population have this inverted pyramid where there's more older adults than younger. So I think we need to be mindful of who's paying in, and they have a different taxation structure there. And when we asked a couple of individuals during interviews, like, we know that your taxes are higher here, but they're like, it's paying for social programs. And we feel like we all benefit from it, from education from our children to healthcare for everybody to those social services. So I think it's part of the culture. Actually, what I've learned is it really is part of the culture. And I think, we need to think about that as, healthcare is not, it's everybody should have access to these types of services.
Taking that 10,000 foot view then, Nikki, if
Yeah.
we're looking at how we're going to change things, just the three of us, how we're going to
Change the
society,
world? Okay.
change the whole world. Absolutely. All of our listeners are going to do it. So with that, if we're taking a 10,000 foot view and we're looking at the biggest barriers to successfully aging within our homes or aging in a community that the United States is facing today, what would some of those be in your mind? What really sticks out?
Well, I'm a pharmacist, as the two of you are. So I focus my lens on medication safety. And unfortunately, this is a tough month, January and February, with medication access. Being out there both in a clinical setting as well as a community-based housing site, over and over again, people are struggling with the cost and access to medications. I think the other thing is access to services. We may think that everybody has access to services they need, but not everybody does. So to truly help people age in place, and that can be basic services from vision to dental care, which are so essential to someone's quality of life and function. And so, and then I think the other public health crisis that I believe is looming is affordable housing. And I think that housing and healthcare go hand in hand. I truly believe people have a lot of stress and anxiety about the stability of where they live. And I don't think we talk about that much. We talk about it in social determinants of health to some extent, but housing and the safety of housing, and maybe I'm sensitized because hearing that conversation, working in some of these housing sites becomes an issue. So those are just a couple of aspects, Kevin, because I'm immersed in them, that I see can truly help someone to successfully age in place. And I'll share with you, I learn a lot from the people I serve. And I had a homeless gentleman share with me, an older homeless gentleman. And he said to me, he's like, Dr. Brandt, he's like, one of the biggest challenges I had when I was on the streets was access to water. Sometimes we don't think about the basic things that we need to survive. And so, so there's lots of things and angles that I could take with aging in place, but I think those are some basic societal things that we need to focus on. And we just had last Thursday was Maryland Legislative Day, where we have our students advocate on behalf of public policies. And we focused on medication-related policies, but there's a lot more policies out there, as I was listening to the bills going by, that I think as healthcare providers we need to be aware of.
I love that. I think those are perfect ones to point out. Let's see, we have a comment here. I'll throw it up. Things dosage packaging and other pharmacy services outsourced in Finland are services on site.
Oh, yeah. That is a great question. So they actually do have these automated dispensing services. And actually the woman that I worked with, Dr. Maria Eriksson, who's a faculty member at the University of Helsinki and my hostess during this meeting, actually just published a great paper talking about automated dispensing systems. And she was saying that it can be part of the solution, but it also can be part of the problem, because people are packaging benzodiazepines that shouldn't be necessarily taken every day in some of these packaging systems. So yes, they provide them, but it just really impresses the importance of a good comprehensive medication review to make sure that those medications are meaningful, which gets at something, Donna, you and I love to talk about, which is deprescribing. And so benzodiazepines are a hot topic with deprescribing. But yes, so some of the sites do provide those services on site, like the day program, as well as the nursing home where people reside, or respite care. But they also do package them up. They deliver them to the home. And we were able to work with some of the home care pharmacists that are working with their teams to provide those services out to the community as well. It was kind of like a hub and spokes. So they had that hub at that center and then spokes going out into their community, which I think is, an important model. And having had the privilege also to do some work when I was ASCP president in Cuba, there's a lot to be said about community-based programs and making sure that they feel connected and providing those supports.
I love this. For the audience, what the dosette packaging or looking at med boxes, all of them are really trying to find a way to make it simpler for you to be adherent to medication. So taking those medications at appropriate times, oftentimes in our elderly populations with decreased level of caregivers that are involved or cognition issues that end up happening, some of those mistakes are quite costly, right? As all of us know. And one problem with having those individual packages of putting all your meds together in one space, as Nikki was talking about, sometimes putting them all together means you also have to rip them all apart to be able to see which ones are being changed in dosage, which ones are no longer needed. And that causes some additional instability, I think, in the space. So I guess really getting to the nitty gritty then, when it comes to that deprescribing conversation, Nikki and Donna, and the ones that you guys have had in the past, any epiphany moments when it comes to our elderly population trying to live successfully at home, sometimes by themselves. We can argue if that's actually successful or not, but oftentimes by themselves. How can we utilize deprescribing at a higher level, a more effective level than we are today?
Well, Donna, I'll let you start with that and I'll jump in.
Okay. So, well, I think part of it too is that basic understanding. And like you said, Kevin, there is a confusion for folks and when they're supposed to take various things, but also if something is being deprescribed, what medicine is it? Is it the one that begins with L and they're on 3 different things that begin with the letter L and they go home, they stop taking the incorrect medicine? So it's really important, I think, that we are very prepared to communicate that, to write things down, make certain that people have things available to them, not only being able to hear it, but see it written down, repeat it back, as we talk about in regards to that teach back method. So I think that there's a whole bunch of things that we as healthcare providers can do in order to hopefully engage the patient and think about what is really going on. I think what's really important too, and Nikki, I loved what you said about the benzodiazepines. Like they really aren't necessarily prescribed every day for every person and on an as needed basis. And I just had a really unique situation where furosemide was being prescribed, but it was really only supposed to be for a few days for somebody. But of course, 30-day supply was provided, and it was kind of a let's see how this goes for you. We know that this is kind of an episodic type of edema, wasn't a common occurrence for the patient. And so in talking with the docs, et cetera, it was decided we'll do 5 days, see how the patient does, and then see if medicine is still continued. But who does that really? Like somebody's provided furosemide and here you go, start taking it. Someone who's an older adult, and here we have electrolyte issues that might ensue and then back into the hospital. So I think that there's so many things that we have to be so careful of and not just prescribe things every day for someone. Even if it's a low dose, it could still be too much. And having those conversations of how long should I really be taking this for, especially if it's for something that is for an acute situation for this particular person. It was a new onset of edema. It was just kind of odd. Couldn't quite figure out why. And then the compression socks worked great. They just need a little bit more extra help with the furosemide. So, being able to do that farm, non-farm, and then get rid of the farm and make things healthier for somebody, I think is really important too. And that doesn't happen when we have these pill pouches, if you will, or people trying to understand how many times do I take this or how many days am I taking this? So a lot of confusion, and we do need a lot of oversight. So it's those conversations and really writing things down, making certain that the person sees it and can follow it.
Yeah. And I think, Kevin, just to add what Donna stated there, I think engagement, communication, you can never over communicate when it comes to utilization of medications. The other thing that I had an epiphany with is you work so hard to stop something, and you kind of, Kevin brought this up before, these adherence programs, which automatically refill something you got rid of and you thought you got rid of it. So it's on some sort of medication list or some sort of, system. So it's just, making sure that there's coordination. And I know this is called the med list. It just baffles me that we don't have like a better centralized medication list, right? And so deprescribing takes a lot of time, energy, and effort. And I've just had too many misadventures where we thought we got rid of a medicine, but all of a sudden they're readmitted, it pops back up, or it gets sent via the pharmacy that we didn't even know existed because it was a,
Yeah, I think it'd be wonderful if we literally had a med list that we could just make a small line through every med we didn't want, and it was over. And it was great for the patient. It didn't hurt anybody. There was no time taken. But I think that's one wonderful thing for the audience that both Nikki and Donna were able to throw in there is the complexities are large. And just to give a quick example, both have mentioned benzodiazepines. Oftentimes some people are taking for anxiety or sleep and multitude of reasons. Coming off of benzodiazepines after being taken for a long period of time and the necessary tapering process for that, very difficult. And oftentimes the consequences and side effects of someone trying to come off that medication by themselves without being assisted and monitored can become so difficult that they don't want to come off those medications ever again. They have a fear component related to it, almost a PTSD, that's why they need to have hand-in-hand relationships with their caregivers, their pharmacists, their physicians in order to do those kinds of things. And it takes that level of complexity, I think, Nikki, to a scary spot, right? It's almost like, do we have enough silos in the United States that avoid us from having some of these hands being held throughout your career, especially since you started beginning of the career to now, which you look about 25. So that's been.
Thank you. It's these filters you guys have in this,
Well, what have you seen happen for patients and for caregivers so that some of those silos that avoid success have been pulled down?
So I'm very fortunate. One of the practices I work at is called the Center for Successful Aging. And the ways we've helped to overcome that is to really coordinate amongst specialists. I think what's been the biggest challenge for me in deprescribing is the multitude of specialists. So sometimes the best conversation is just to reach out or to limit where people go for some of these specialists. We want to give people choices, but within reason. And some practitioners, honestly, in my opinion, this is my opinion, are more age-friendly than others when they think about how they prescribe the medications, and they think about non-pharmacologic maybe before they go to pharmacologic treatment approaches, especially from a psychiatric perspective, which, we have a lot of coexisting depression, anxiety, sleep disorders, and we have to be very judicious with the medications we use. So that's been, I think, a way is to sometimes say, maybe more isn't better, both from a medication perspective, but also from a provider perspective. But you need someone who's going to help really coordinate that. So we have some strong geriatricians and people within our health system that we work with closely to try to de-escalate, deprescribe medications when we can. But to your point, Kevin, you brought up a really great point, especially with benzodiazepines, is this physiologic and psychologic dependence, and some people are insistent, like, I just need to have this pill because they feel this connection with it. So just being mindful of how we embrace that conversation, but work with other team members to support each other.
Right.
Tremendous.
Yeah.
And I always like to add to that, we have to be thinking about how many years we've been taking a particular medication for, and is it really still the right medication? Because our bodies change, and out of these many years, so hasn't situations changed. So what might have triggered some need 20 years prior might have resolved. And yes, we still have the drugs that remain, and that's a worthwhile conversation to say, can I start to taper off of this slowly, and work with people? I love the idea of the pause and monitor, where let's just pause this, because even if you stop something or reduce it and it just isn't the right thing and you feel that it's necessary, and for monitoring purposes, there is a reason for the need for it still, then by all means, you can go back on it. It's not, I wish that people weren't so fearful thinking, oh, if I start to reduce this, I'll never get to go back to what I really need if I need it. And that is so not the case. And I think that that's important to relay that to folks when we're speaking with them and talking to them about medicines, continuing meds, or deprescribing them.
Yeah. No, Donna, it's a good point, because sometimes we also need to optimize certain medications they're taking, and how do we support them with that as well?
Yeah.
I love that transition, Nikki. If you did it purposely, bravo, that was genius.
Oh, thank you. that you have, Kevin? Okay, good.
Just like T-ball, it's
Yeah.
fantastic. But I do think that the transition that we're kind of looking at, oftentimes when we're looking at these interventions going in place, we don't think of, if I'm taking these medications, am I going to be able to be successful by myself in aging, right? And so the real question to me is this: we have in our country, that many of the viewers may kind of recognize, we have a lack of caregivers. In fact, I was just reading an article the other day that but because of a lack of availability of sick leave, of whatever the case may be, they literally have their parents at home by themselves, sitting in their wheelchair with no one to come and help them with activities of daily living. I mean, it is an awful situation for some communities to have to deal with when you just don't have the help that's necessary. And so I think because of that, there's a few different socioeconomic things that would have to change, but we're really focused here on the medications today and hopefully having some independence of people aging successfully. What things have you noticed that either one, we're doing with our drug regimens over a period of time unsuccessfully or successfully to be able to allow people to stay in their own homes and stay safe and age well?
So I think those are really important points, Kevin. And I have to pause because not only do we have a shortage of healthcare providers that focus on aging, we don't have enough people that want to go into caring for older adults. So more needs to be done, more value in that, both from a payment perspective, but also from a societal perspective. So I think that's really important. To help people age in place from a medication related perspective, I'm a big philosopher of keep it simple, right? And unfortunately, some of these regimens are really complicated. And so to think about complicated, not just from the pill burden or the treatment burden, but sometimes the monitoring perspective. And so, I've had patients who are advanced illness with their cancer and have to think about, like, do I really want to go through this next infusion, this next clinical trial? And I have to think back to one of the patients I lost last year who himself was a pharmacist. And we had lots of conversations on what matters to you. And what mattered to him was being with his family and seeing them and not being in a bed, getting another infusion. But those are, context of conversations of what's important and where our goals of care are. And I think as a society, we need to think about how we train people to have those complex conversations. And I think as pharmacists, we need to think about how we, also convey that to the rest of the team. So, we talk about costs, but we also need to think about complexity because sometimes these regimens are very complex. And I think something that we can often relate to is warfarin, right? Yeah. And the use of these direct oral anticoagulants. And it's lovely because they don't have to come in for monitoring, but my patients can't then afford sometimes their meals because they have to pay for the medicine. So I just wish from a society perspective, we could keep it simpler, but we can also keep it affordable because that's been a challenge with some of these medications. And I know there's policies in place to make it better. And I guess I was told today at a program 2025 looks promising because some of the caps and limits of drug out-of-pocket expenditure. But I think that's really important. And I think that burden of stress, if we think about it, the financial stress with making those tough decisions can make someone exponentially age because it really causes a lot of difficult choices at times. So I think that's it. I also think when we think about lessons we learned from the pandemic, is thinking about how we deliver care. And I think we need to continue to meet people where they're at with how we can deliver care, but also making access to platforms like this with webinars and others more friendly for older adults to get that kind of care in their home. I can't tell you how much I learned from having the computer with the child in the home, and such an important aspect because none of us all have that ability to go to home visits, but it opened up kind of that lens to what's happening in the home from maybe a safety perspective with medications and other safety concerns or opportunities to improve. So I don't know if I answered that concisely, but I think it's getting at kind of there's a lot of different angles that need to be focused on to help someone age in place, and it really needs to be centered on that person.
But the one thing that I wanted to highlight with that, Donna, is just that quality of life aspect that Nikki said with the cancer therapy. There's recently kind of some petitions and pushes for longer duration clinical trials to be able to look at the quality of life aspects over a period of time when we're going through some of these things. And I think those conversations are just too important to just leave to one, therapeutic window. We've got tons of drugs, that quality of life conversation needs to happen earlier rather than later. And then the last thing I wanted to plug, though, that Nikki said for the audience is, if there is a way for caregivers to become more involved in their family members' care earlier, if that is a relationship that's already been cultivated and is available, then please do it. Like, we've seen the outcomes are just better and better and better. When Nikki said, when the child is in the home, I mean, that child is all of these individuals that are on the screen right now, taking care of their aunts, uncles, mothers, grandmothers, et cetera. And I think that is a massive uplift when it comes to dealing with that monitoring, communicating with those clinical teams and all those pieces. But Donna, off to you.
Yeah. Yeah. So you started talking about it a little bit, Nikki, when you were talking about what matters,
Mhm.
but we know that age-friendly environments and efforts look at the 4 M's. And I would love for you to take us through the 4 M's, if you don't mind, in thinking about that and the importance of addressing the 4 M's for aging.
Yeah. So, Donna, in full disclosure, I've been fortunate to be a part of the age friendly health system movement as both a faculty and an advisor. And so, for those who are listening in, age friendly healthcare systems focus on the 4 M's: what matters to patients, which is really getting at person centered care; medications, focusing on, again, medications that are meaningful to get at what matters, but also getting rid of medications that might be problematic, especially with the context of the other 2 M's, which is mobility. And we know some of these medications can potentially increase the fall risk in our older adult, but also may help with mobility, especially if we're helping manage pain better. So there's that balance with anything. And then, of course, mentation. And mentation, when we think of mentation, we may think of cognitive function, but we also need to think about delirium and depression. And Kevin was mentioning a little bit about social isolation, because unfortunately, throughout the pandemic and beyond, people are still socially isolated. And we know that can really impact someone's quality of life and length of life, actually. So, so the 4 M's is kind of a framework based on evidence-based practices that have existed for a long time. But Donna, unless we simplify things, right? Just like we simplify medication regimens and we put it in a package that people can relate to, then it's more and easier to implement. So when we started this, and this is a John A. Hartford Foundation led project with the Institute for Healthcare Improvement and other organizations, but when this got started, it was only 5 pioneer health systems. Now, approximately, I think there's over 3,700. And there's multiple countries getting involved in this movement, because we know that, again, aging is happening globally, some more than others, but we need to think about how we provide that care. So as part of the faculty and advisor with this work, again, I've had the opportunity to talk with people from different countries on the aspect of this, but also here locally with different health systems. And one thing that I think is so empowering for pharmacists as a team is they feel like they're helping to be more included in breaking down those silos, as Kevin mentioned, and feeling like they're empowered to make a difference. And I think that the thing that most resonates with me is that what matters, right? And giving context to the conversation. Are there any medications that you're worried about? Are there medications that are interfering with what matters to you? And though it's hard to measure, it is probably the most meaningful impact, because people are like, yeah, that one medicine that makes me feel woozy after I take it and I can't get out of bed. A simple way to kind of give construct to that conversation to help them feel engaged and empowered. And I think that's a very important role of pharmacists wherever you practice. In the hospital, in the community, in long-term care, you can be an extension of advocating for your patients.
Yeah.
And the caregivers, because they often feel like they're stuck in the middle. So I think I just want to bring that out as well.
Yeah. I think too, and you bring up a great point. I know that medications has its own area, but you're saying like even what matters with your medicines. And we can think about that as to what matters, that you might not want to stop something that we think is potentially something that you could be stopping, or what matters to you down the road. Like, is it that quality, or do you want heroic type of medicines in order to, take care of some health condition that may or may not be appropriate, or give you a good quality of life, but maybe taking that medication is important to you. So I think when we look at that, and as you also pointed out, the whole movement and cognition, all of it is affected by medications. And I can't help but just take a second and parallel that to something that I always am teaching the students is, so what causes falls? And we know that there's so many things that can cause falls. And we talk about gait and vision and hearing and um, orthostatic hypotension and so many systems, right, that can increase our risk of falls. Knowing that medicines can also affect all of those things. So I can't say enough how important it is. And I know that medicine is just one part of that 4 M's, but man, does it bleed out to all those other areas, and really is quite I think, a big pillar that's really holding everything up, I might
And,
add.
and Donna, the forums are meant to be a package, right? So when you put these programs together and you measure the impact of your health system or your care setting, is you're looking at everybody getting that same kind of delivery of services, focusing on all forums at one time.
Sure.
Yeah.
Wow. Now, I did have a comment here that I threw up on the screen, but we didn't talk about. I think it's a good time. We need more. This is once again Praveen, which is thank you so much for these great, insightful comments. But we need more mobile pharmacy services going into the aging patient's home and doing med recs. And I think all of us would say yes, we agree.
I like to call those med revs. Sorry, had to interject there. Med revs.
Comprehensive.
Sure. Angle that C over a little bit. You know, it's just on its side, and now we have med revs.
Yeah, I think, that is a really important point. And I think wherever you practice, whatever state, country that you're practicing in, advocating for you to be that person doing those, I like to call them not just medication reconciliation, but those comprehensive medication reviews and focusing on kind of the medication related problems that are most impactful to the person and their quality of life, function, and aging process. So I agree, whether that's in the home, whether that's with tele services, but just having learned that we just need to make those tele services something that are ideally bi-directional more and something that are more age friendly in terms of the platforms that we focus on. And I know there's lots of technology, and I'm sure Kevin could help educate me even more with some of the technology, but I think it's access and equity that becomes sometimes an issue. And I had an opportunity. I worked with Health and Human Services on some of their work with programs, and we wrote a letter of support for our rural communities. And I know, Kevin, you shared a little bit about your background and your family history there, but in having these low orbiting satellites, so people could get access to internet in some of these rural communities, because that's the only way they could get health care. So just thinking about access and equity and not just the technology. So there's a lot of angles where pharmacists can be pivotal. And I think pharmacists, again, I just advocate that we got to make sure we're not causing pharmacy deserts in what's happening in our communities. A shout out to my colleagues, especially in the Midwest. We've been doing some work with colleagues in Chicago, where some of our communities just don't have access to local pharmacies. And we just need to think about that in terms of some of our public policies. So hoping some of you are doing some work in that space, but I know that our older adults in particular use their community pharmacy as a part of where they get their health care and resource and information from, because they trust their pharmacist.
Definitely. And I think it's an interesting thing when we talk about who we trust, right? Mm-hmm. That we have different generations that had a higher level of trust than the next generation. So we're seeing that we went from, a lot of us for our career, we're working with the greatest generation. And when it came to like the stereotypical greatest generation patient, there were certain paternalistic approaches that were still rather successful within that group. And now that we're seeing the boomer generation, the millennial generation come around the corner, I guess I'll stop it there, because I'm guessing a lot of our audience, please don't feel like I'm ageist in any way, shape, or form. I am a millennial, so I'm in that space. But are there any things that you guys are noticing when it comes to aging at home that, yes, we have a generation that is passing away that we're going to miss deeply, but now that we're seeing this next generation come in that has an independent mindset, that has at the very least, a shared decision-making mindset, how can we start pivoting in not just the pharmacy world, but just in general medical approaches to take care of those patients better?
I think is making sure, Kevin, this is a really good question. And what I'm noticing more, even just in my evolution within our practice, is how many more families and patients are using patient portals and asking lots of questions. and how can pharmacy and pharmacists help navigate some of the mistrust or misinformation that's out there. And I think being a reputable as well as trusted resource for people, because I think we've all had our share of experiences, and we could use the topic of vaccinations as one of them. But I think, again, being at that crossroads of public health and helping to reestablish trust that might have been lost at some times. And I think there's lots of different generational perspectives there. But I think we need to be mindful of that, and we need to have open conversations about that. Where are people getting their information from? Because a lot of questions are being asked. And I think that's the generational shift I'm seeing more with kind of I call them the younger old versus the older old, in terms of where they're getting information, who are they asking, and seeking out multiple sources of information.
Love it.
If I can interject, and it might be a hot topic, but I just think it's so important too that pharmacists, because we are accessible, and I just think that we need to be able to be paid for more than just dispensing at the community pharmacies. We really need to have the backing of what we're able to really provide patients, and be able to use that almost like an office visit, right? Where you have a few minutes with somebody. How kind of different is that necessarily, in that you can document that you did a consultation, whether it be on a drug or many drugs, versus just dispensing. And I don't mean just dispensing. I don't mean to sound that way, but I think it's an important part of what we do. And if there's somehow, some way in this world that we can just, fill a consult, it might be a worthwhile thing just to show our worth. And if people aren't having to go to the doctors as much, or things are being taken care of, especially in rural places, like how wonderful would that be, to be able to have the time? Because I think pharmacies and pharmacists would feel like they have more time versus these long queues of filling prescriptions only.
Yeah, Donna, and you bring up a great point. And I think every state has different regulations and legislation that's getting looked at. And I know, just again, here in Maryland, we just started in January of 2024 getting paid by the state for MTM services and other services. So, I think we all need to keep up that advocacy efforts and learn from each other. More than willing to share. We finally got recognized. Now we need to make sure there's payment parity, right? So I'll put my business hat on, because you can't sustain a business if you're getting paid at a very low rate. So there's recognition of providing a services, but also getting paid in a way that's you can maintain the business, right?
Right.
So I think that's important as well. But yeah, I 100% agree, is continuing to show value added. And I know that we sometimes think it's just pharmacists, but every healthcare provider continues to have to show their value that they bring to the team, and also to your patients, right? And I think our older adults can be one of our biggest advocates if we empower them more, which gets at the elder. I just want to do a plug here for the Elder Care Medicine Network and some of the work that we've done with Patient-Centered Outcomes Research Institute, which is bringing the voice of the older adult to some of the research and what's meaningful to them. So topics like deprescribing, simplifying medications, engaging caregivers in meaningful ways when it comes to decision making are things that they would like to get more involved with. And also just understanding this safety aspect, especially with over-the-counter natural products and prescription medications. And that's just a huge area with the explosion of things that are readily available to our older adults to help, as we talked about, Kevin, earlier, anti-aging, right? So we just need to be mindful of the safety implications of some of the things that are being kind of disseminated out there.
Yeah.
I love that. Yeah, I think that the relationship element, as we see technology and medicine continue to evolve, we're seeing that the dissemination of education or information back and forth is at a whole different level. We've had Dr. Google for a long time, but the new doctor that's in town is a lot smarter than Kevin, right? I mean, we can look things up and be able to connect the dots really quickly, but what can't be done is strong foundational relationships being formed between patient and caregiver, and between colleagues within that kind of environment and ecosystem, to be able to pool together that knowledge and leverage it and filter it appropriately. And I think that is a real nice testament to when it comes to the 4 M's, and having the ability for us to pull all of those elements together nicely, so we can coordinate that level of care and information. So it is not just one Google search and this is how I'm going to change my care paradigm. And it really is a shared decision between patient leading the team and their care collaborative team, kind of helping them along the way in a very assistive manner. So I appreciate that time, Nikki, that you've given us today. I'm sure the audience is all very thankful for all the wisdom that you've shared, and any closing words that you wanted to part with and make sure it wasn't left on the table.
No, I shared some images with Donna that could help provide resources for your audience in the future. But I think, Kevin, I just want to share that you brought up a great word, ecosystem. And I think when we think about age-friendly, I think we need to think about the ecosystem in which we work, but bigger than that, in which we live, right? And think about the intersection of policies, healthcare, services, and sustainability. So I think about that because that's what's really important, especially with our aging population.
And Nikki, we will put those slides up.
Okay, perfect.
With the information. So thank you for that.
Awesome.
Yeah. So again, thank you so much for being with us and sharing your extensive knowledge on age-friendly efforts and really thinking about how to tackle this. I know that there's a lot of work to be done, and I can't wait to see where all this lands, right? And just see the progress that we can make. And what you're telling me happens in Maryland, I'm only too excited to see that move throughout the country.
What happens in Maryland can't stay in Maryland. Okay?
No, it's
Oh
not.
no, but we learned from other states, so I can't say it's just happening in Maryland. So
Right. No,
yeah.
and I know that. And I know that there are some states, it's just, it's everything takes time. And yeah, it's wonderful what's going on in your work. So thank you.
Oh, well, thank you. And thank you for this opportunity to share. And please, if people have questions, feel free, Kevin and Donna, to share my contact information. And our LAMI Center resources are for free. Anything that's there can help you help others. That's why we put it out there for you.
Awesome. Awesome. Thank you, audience, for joining. Thank you, both Donna and Nikki, for all your commentary. And we'll catch you on the next episode of MedList.